This conference will now be
Am I clear?
recorded.
Yes, ma'am. Audible, ma'am.
Jyoti Prakash. Okay. Screen is also visible. Screen. Is everything is okay? Then I will start. Good afternoon, everybody. Today topic is dengue fever in pediatric age group. Why it is important? Why you should, as a 7th semester student, why we have to learn about dengue fever? Anybody? What is the importance of dengue fever? Why you should learn? Can anybody name the other name for dengue fever? Otherwise called as dengue fever, otherwise called as
Breakbone fever, ma'am.
One more name is also there. What is that? Dengue fever or breakbone fever, or depending upon the fever type, it is actually biphasic fever. The child and the person may have 2 times. In between, child may be fever free, febrile. Again, they will have fever. That's why it is called as saddleback fever also. Okay, why you should learn means because clinical presentation is varies. Typical and atypical presentations are there, and few diagnose and monitor carefully, and if you treat, mortality will be very less, like 2 to 3%. Undiagnosed and not properly treated, mortality rate is almost 20%. For that purpose, you should know when to suspect dengue fever, when do you call it severe dengue, when you have to reassure the patient or patient attendants. For that purpose, you should know the clinical features and epidemiology of dengue fever. This will be useful for you for community medicine, that is SPM exam also, and general medicine and pediatrics, and as such, you should know. Dengue is the one of the 10 leading causes of hospitalization and death, especially in pediatric age group. That's why you should know. And globally, around 50 million cases per year are occurring. Among these, mortality rate is around 2.5%. But without proper treatment, case fatality rate may be increased to 20% in severe dengue. So I will tell you when do you call severe dengue, what are the features of severe dengue also. So all of you should know what are the typical and atypical presentation of dengue fever, so that you can suspect early and you can diagnose and treat and prevent the deaths in pediatric age group due to dengue fever. What is the vector here? It's a arthropod-borne disease. Can anybody name the vector?
Aedes aegypti, ma'am. Aedes, ma'am.
Good. Aedes aegypti. Okay, good. So dengue fever is also known as breakbone fever. These are mosquito-borne or arthropod-borne. We call as arthropod-borne tropical disease caused by mosquito bite. Why it is called as breakbone fever? Because these patients will have muscle pain, myalgias and arthralgias, joint pains. That's why it's already given breakbone fever. And as she already told, this is caused by female Aedes mosquito bite, which transmits the dengue virus to human. How many serotypes are there in the dengue fever? Anybody can name? I think you already read in microbiology and pathology also. How many serotypes are there? Dengue. There are 4 serotypes are there. Each will have clinical presentation is similar, but antibodies produced by one dengue virus won't protect against the other serotype. That's the problem with dengue. So dengue belongs to the family Flaviviridae, and genus, as I told you, there are 4 serotypes in Flavivirus genus. That is Den1, Den2, Den3, Den4. 4 different serotypes are there, and antibodies produced by Den1 won't protect against the Den2 or Den3 or Den4. And on the top of that, this can cross-react excessive activation of complement system and further deterioration of the condition of the child. That's why it's very important. You should know that there are 4 different serotypes. They won't protect against, antibodies produced by one serotype won't protect against the other serotype. So there is no cross protection between the serotypes. Coming to the epidemiology, it is transmitted by mosquito bites of Stegomyia family, that is Aedes aegypti. It's a daytime biting mosquito. The principal main vector, this is the female, especially female mosquitoes, which usually bites in daytime. These species breed in water trapped in vegetations like stored water in coconut water, trapped in coconut shells and all those things. So you should take proper precautions to dispose these used coconut shells and other things. Epidemics were very common in temperate areas of the America, Europe, Australia, and Asia. So these are the vectors. Most common is Aedes aegypti, and rarely Aedes albopictus also can transmit the virus from the one human being to the other human being. Coming to the pathogenesis, actually there are so many complications, but pathogenesis is not yet completely understood. But what is hypothesis, what is proposed pathogenesis is mainly due to circulation of infection enhancing antibodies. At the time of infection is the strongest risk factor for the development of severe disease. That means secondary infection, already the child or the person had infection with one serotype, there is antibodies that is called as infection enhancing antibodies. Second time the person got the other serotype, same serotype, these antibodies will protect. But with other serotype, it acts like infection enhancing antibodies. So complications will be more. So it is observed that the sequential infection with any two of the 4 serotypes of the dengue virus will result in dengue shock syndrome, especially in endemic area. Previously, they used to call dengue hemorrhagic fever. This word now they are not using. Now they are, instead of dengue hemorrhagic fever, they are calling as dengue shock syndrome. So antibodies produced during the first infection are able to neutralize a second viral infection with the same serotype only. So there is already the child, especially in endemic areas, they more frequently get this dengue fever with one or say other type of serotype. So same serotype, these antibodies will protect with the same serotype. But if it's other serotype, propose that serotype cross-reactive antibodies will be generated from the previous infection. These will bind to the virions, but they won't neutralize them. So what happens if the child got infection with second time with second or 3 or 4 serotype, any serotype, they will get infection and antibodies will be produced. But these antibodies will have cross-reactive and they will bind to the virions, but they won't neutralize them. And instead, they increase the uptake by the antigen presenting cells. So they exaggerate the disease process.
Continuation consists of 2 parts, and it consists of 2 parts. 1 or 2 better. Continuation famous epithelium. Okay.
Rapid active, then what happens with cross-reactive antibodies? They bind to the virions and increase the uptake by the antigen presenting cells. If it is with another serotype, this will lead to rapid activation of complement system and also release of cytokines. So this contributes to the activation of complement system and release of cytokines will leads to the dengue shock syndrome. So mainly what happens, capillary leakage will happens and internal redistribution of fluid resulting in hemoconcentration and hypovolemia. Fluid is redistributed, so intravascular volume will be decreased, that leads to hypovolemia and shock. And further decreased intravascular volume leads to decreased tissue oxygen supplementation. So tissue hypoxia, whenever there is hypoxia, there will be metabolic acidosis and hyponatremia. These are the, and further in turn increases the cardiac workload. So this is the main pathogenesis in dengue fever. And along with this, there is a molecular mimicry between the dengue virus proteins and NS1, that's mainly NS1 protein and platelet proteins and other endogenous cell proteins. So damage of the platelets and other cell proteins will take place, leading to thrombocytopenia and activation of blood clotting system and fibrinolytic pathways. So there will be disseminated intravascular coagulation with the activation of blood clotting system and fibrinolytic pathway. This in turn leads to intravascular, that is disseminated intravascular coagulation. On the top of that, there will be liver injury. Sometimes hepatitis also, virus itself can cause inflammation of the cells, and viral hepatitis due to dengue fever, and thrombocytopenia, as I told you, it's due to molecular mimicry. All will contribute to the hemorrhage. They may present with mucosal hemorrhage or massive hemorrhage also. So coming to the clinical features, as I told you, varying clinical presentations are there. Some people only they will have fever and with or without rash, and some people will have fever and throat pains, that is sore throat, and some joint pains like that. Without any complication, they will recover. Some people will go for the dengue shock syndrome also. So it's unpredictable. Clinical evolution and outcome in dengue is unpredictable. So we have to closely monitor the children, and you should know what are the signs which warns you that the child may go for dengue shock syndrome. Those signs are called as warning signs. And coming to the incubation period is between 3 to 7 days. After mosquito bite, they may develop clinical features after 3 to 7 days. The classical presentation of dengue fever can be described in 3 phases, that is febrile, critical, and recovery. These are 3 phases. All of you should remember. You may get question in your community medicine paper, theory paper also, or in pediatrics and general medicine. So in febrile phase, that's initially when the child develops fever, usually there will be a high grade, sudden onset of high grade fever for it lasts for 3 days or 4 days, it varies. It may last for 2 to 7 days, and there will be associated facial flushing, skin erythema, body aches, myalgia, that is muscle pains, arthralgia, joint pains, headache, and there will be nausea, anorexia, vomitings. So in febrile phase, child will be having these features, and sometimes they may have present with along with fever, sore throat, like it may mimic pharyngitis, and sometimes conjunctivitis, injected pharynx along with the conjunctival injection also there. So these all features will be seen in febrile phase. If you do tourniquet test, it may be positive, and sometimes minor hemorrhagic bleeding gums may be there. So usually febrile phase means fever, joint pains, muscle pains, headache, sore throat, facial flushing, skin erythema. But this erythema will be blanchable. There is different rashes in dengue. In febrile phase, one type of rash, and recovery phase, another type of rash will be there. So this is the rash in febrile phase. So if any child with fever, erythematous rash is there over the trunk or chest, just blanch with your hands, with palms. You can see blanching. This is a blanchable erythema. Usually same typical of febrile phase of dengue fever. So what we have to take care here means febrile phase, because throat pain is there, nausea is there, child may have vomiting, so we have to take care of the dehydration, prevent dehydration. Plenty of oral liquids we have to give, and paracetamol to decrease the temperature, because viral there is no need of any antibiotic usage. Just to differentiate between the rash in febrile phase and rash in recovery phase. This is different. I will deal later. It's only seen in case of recovery phase. Here it is non-blanchable. This rash, erythematous macular rash, is non-blanchable. Ideally, it is typically described as white islands in the sea of red. In between the erythematous rash, there is small area of unaffected area. These are called as white islands in the sea of red. This is a typical feature of recovery phase. Febrile phase, one more thing, if you examine carefully, hepatomegaly will be there after a few days, 2 to 5 days, and there may be tenderness of the hepatomegaly. Tender hepatomegaly always indicates that child may go for severe illness. It's a warning sign. So any child in the season where dengue fevers are coming, or if you suspect dengue, always palpate abdomen for hepatosplenomegaly. There is a hepatomegaly and tenderness is there. it's a warning saying should admit the child and carefully monitor for the development of severe illness. And there is associated decrease in the white TC, that is total white cell count. Leukopenia will be there, and platelets also decreases, but gradually, progressively decreases. So leukopenia and thrombocytopenia will be there. Coming to the critical phase, this is very, very important. In febrile phase, only you should take care of body pains, joint pains with analgesics and paracetamol. Don't give brufen and indomethacin type of drugs. Paracetamol is sufficient because they further aggravate the platelet damage and further aggravate the thrombocytopenia and bleeding manifestations. So better to restrict for the paracetamol, acetaminophen only. Don't go for brufen and indomethacin type of drugs. So coming to after febrile phase, there will be critical phase. So here fever decreases 3 to 7 days from the onset of fever. Defervescence will be there. The patient may show bleeding and shock with fall in platelet count. So here critical, that's why it's called as critical phase. The child may go for bleeding with or without shock. But associated features are platelet count will be decreased and increase in packed cell volume. That is PCV usually will be around 60% in normal individual, will up to 65 okay, but beyond 65% increases, packed cell volume will be increased. And other organ dysfunctions also will be observed in this critical phase, like severe hepatitis, encephalitis, which is a liver, severe hepatitis. It's a brain, it's a encephalitis. Heart, they may manifest with myocarditis, like tachycardia, and later they may go for cardiogenic shock. And severe bleeding manifestation will be there with plasma leakage and shock. So this is a critical phase. Here we have to admit the child in emergency room, pediatric ICU, and we should take care of the shock and bleeding. And multi-organ failure also. Any organ can be affected. If it is passes through this febrile and critical phase, then is the recovery phase. After 24 to 48 hours in critical phase, a gradual reabsorption of extravascular compartmental fluid, because initially there is a leakage, so that's why leading to hypovolemia. Now reabsorption from the extravascular compartment into the intravascular compartment. This will take place next 48 to 72 hours. So what happens properly not properly managed, this may lead to volume overload. Volume overload can lead to pulmonary edema, sometimes congestive heart failure also. So usually these children will be general well-being improves and appetite returns, because initially in febrile phase they will have anorexia and nausea. Now they will have good appetite, and gastrointestinal symptoms also subsides. And the child may be hemodynamically stabilizes and diuresis occurs, because reabsorption of extravascular compartmental fluid takes place. So they may manifest with increased passes of urine, that is called as diuresis. Some patient may have, as I told you, it's a recovery phase. They may have islets of white in the sea of red. This type of rash. This type is a recovery rash in the recovery phase. In recovery phase, there may be sometimes associated with this rash may be associated with pruritus, itching, and heart rate maybe falls, that is bradycardia, and ECG changes may be there due to myocarditis, that is decreased amplitude in the waves. Respiratory distress due to pulmonary edema is uncommon, but may present with reabsorption of fluid leading to increased intravascular compartment and pulmonary edema, and may manifest with respiratory distress in recovery phase. And packed cell volume usually stabilizes, sometimes maybe goes down also because of dilution. But BP will be normal. You have to think that maybe due to dilution. BP is low and packed cell volume PCV is also decreasing, means we have to think about acute bleeding, and we have to replace with blood transfusion. And white cell counts also rises after defervescence, that is fever subsides. Recovery of platelets, it takes time, longer time than the WBC counts. So WBC counts comes to normal compared to the platelets earlier. And especially in immunocompromised children, there is more chance of organ dysfunction, and also it takes more time for the platelets to come to normal. This in case of dengue fever in immunocompromised children, maybe congenital or acquired immunocompromised status. Coming to the warning signs, that actually WHO classifies dengue fever into probable dengue, laboratory confirmed dengue, dengue with warning signs, severe dengue fever. So when do you say dengue with the warning signs? If these signs are present, like abdominal pain or tenderness, persistent vomitings, clinical fluid accumulation like in ascites or pleural effusion, mucosal bleeding from gum bleeds or GI bleeds. The child is lethargic and restlessness, that indicates CNS, encephalitis, liver enlargement more than 2 centimeters than the normal, and increase in packed cell volume with concurrent a rapid decrease in platelet count. So these all 7, any one sign with dengue fever indicates warning sign. That means the child may go for severe dengue, that is dengue shock syndrome. So you have to monitor these children very carefully and immediately diagnose and treat the complication, then mortality will be very less. Sometimes they may ask for 4 marks, warning signs in dengue fever. Coming to the severe dengue or dengue shock syndrome, when you will suspect, there are clinical and laboratory features. These are the clinical features like acute onset high-grade fever, hemorrhagic manifestations like positive tourniquet test, tender hepatomegaly, effusion in the body cavities, under shock. So these are any findings are there, clinical criteria. Then acute onset of high-grade fever with hemorrhagic manifestations, tender hepatomegaly, effusions in body cavitation, under shock. That's a dengue shock syndrome or severe dengue. Laboratory criteria usually associated with severe dengue are thrombocytopenia, that is less than or equal to 1 lakh cells per cubic mm, less than 1 to 2 platelets per oil immersion field. Any feature less than, total count is less than 1 lakh per cubic mm, or for each oil immersion field less than 1 to 2 platelets per oil immersion field, also called as thrombocytopenia. And rising hematocrit, that is PCV, is more than 65%. So tourniquet test is also very, very important. For pediatrics, they may ask for 2 marks or 4 marks question also. This test is very important according to WHO is a case definition for dengue. Presence of 10 or more PTK per 1 square inch indicates a positive test. But usually it will be more than 20, 30 also we can observe in case of dengue fever. Almost present in 50% of the cases, more than 50% of the cases. If you do tourniquet test, it will be positive. How will you do? We will apply a tourniquet with BP cuff, BP apparatus also we can tie, but we have to measure the blood pressure. If you take the normal individual's BP, which between the systolic and diastolic, midway between the systolic and diastolic pressures, we have to keep the inflate the cuff for 5 minutes. Then if you inflate and if you observe, the test is considered positive and 10 or more, usually it will be 20, more than that also, in a 1 square inch area. That is 1 square inch means 2.5 centimeters square. So that dengue fever, the test usually gives definitive positive results, usually more than 20, but to say it's positive, more than 10 or more is sufficient. But sometimes maybe negative or mildly positive during the phase of severe shock. So other criteria like lab confirmatory and other features suggested. But in case of febrile phase, if you do it, it is usually positive. So here you can see PTK purpuric rash here all. But if you take 1 square inch, that is 2.5 centimeters square, if you count these PTK, here you can see it's almost more than 30 or 40. So, but more or can is equivalent to positive tourniquet test, indicative of dengue fever according to WHO criteria. If there is a fever and other features are there, the child gone to travel to endemic area or is living in an endemic area, then we have to think about dengue fever. So these are the phases I already described. These are the phases like febrile phase, critical phase, recovery phase. What happens to temperature? What happens to clinical issues? What are the laboratory changes? What are the serological and virological tests we can do? It's a course of dengue illness. So initially, In febrile phase, child will have high grade fever, rapid rise of high grade fever, more than 40 degrees Celsius, like that will be there. Usually last for 1 to 3 days, febrile phase. Sometimes may last for 7 days, but usually up to 3 days is normal. During that phase, usually clinical state child will be febrile and dehydrated. Tongue will be dry, oral mucosa will be dry. So you have to take care of hydration by more number of oral fluids. If is unable to take orally, then you have to give through the IV fluids. And coming to the laboratory changes, initially everything may be normal. After 2-3 days, there may be decrease in the platelets. Gradually, not sudden. In critical phase only, more thrombocytopenia will be there. But febrile phase, only late phases may be slight decrease in the platelet counts. But hematocrit also, but no changes, are apparently slightly elevated PCB. But febrile phase, only changes we can see, child will have high grade fever and features of dehydration with myalgias and bone pains. And tourniquet test, if you do, it may be positive. And virologically, very high viral load will be there in febrile phase. If any mosquito bites this child, there is more chance of transmission to other children. Also viremia, acute phase, it will be transmitted. And serological test, if you do, we can go for the virological RT-PCR test, or maybe serology antibodies. It takes time, at least 6 days. After more than 6 days only, we can see the IgG, IgM antibodies. So coming to the critical phase here, fever decreases initially. You can see effervescence. So parents may think that child used to have very high grade fever. Now it came to normal, means they think that child is normal. But here is the critical phase. Here, this is the main phase where parents and the doctors has to monitor the child for urine output, because in case of hypovolemia shock, there is decreased urine output will be there, and bleeding manifestations, bleeding gums, or passing black color stools, melena, or other features. Okay, and if you do laboratory investigations, here you can see platelets. They may decrease to very low levels, less than 1 lakh. But PCV, it rises. Hematocrit value rises. Okay, critical phase. So here we should take care of the shock and bleeding manifestation. Next, coming to the recovery phase. What happens in recovery phase? Usually, child fluid, whatever there in the extravasated fluid, will be reabsorbed. So, if anybody given more fluid in critical phase, there is more chance of fluid overload and pulmonary edema. Okay. And platelets gradually rises. PCV may come to normal, or maybe due to dilution, it may be low. But if you do serological investigation like IgM and IgG, usually IgM will be elevated first, followed by IgG. And also, as I have told you, we can observe different types of rash in case of dengue fever. Initially with febrile illness, erythema with blanching rash, and recovery phase erythematous rash, unblanchable. That's islets of white and red sea, like that appearance will be there. It's non-blanchable rash. So coming to the classification, it's according to WHO, how you will classify dengue. Dengue without warning signs, dengue with warning signs, and severe dengue. There is no dengue hemorrhagic fever. Those words are removed from the recent classification. All of you mute yourself. All of you mute yourselves. So criteria for dengue with or without warning signs, when you say probable dengue means if your child or the person is living in a dengue endemic area, or he travel to dengue endemic area, and fever present, and any two of the following criteria is there, then we call as probable dengue. Like the child is having nausea and vomiting, a rash, erythematous rash, body pains and joint pains, muscle pains and joint pains, tourniquet test positive, leukopenia, and any warning sign. The probable dengue. If it is confirmed with lab, then we call as laboratory confirmed dengue. Coming to the warning signs, abdominal pain or tenderness, persistent vomitings, clinical fluid accumulation in the form of ascites or pleural effusion, mucosal bleeds, the child is like altered sensorium, irritable, then is indicates CNS involvement, liver enlargement more than 2 centimeters in size, more than the normal size, and laboratory wise increased hematocrit value and decrease in the platelet count. This is a warning signs. So these children requires immediate admission into the hospital and close monitoring. Under medical supervision only, we have to treat these children with warning signs. But children without warning signs, that is probable dengue and laboratory confirmed dengue, we can send the child to home and we can advise the mother to give liquid oral fluids and antipyretics. Criteria for severe dengue. When do you call severe dengue? So severe plasma leakage in the form of shock, that is dengue shock syndrome, or fluid accumulation with respiratory distress like pleural effusion or ascites. The ఒకసారి mute all పెట్టమ్మా ఉందా? మధ్య మధ్యలో వాళ్ళు severe bleeding and severe organ involvement. How do you know severe organ involvement? If you do liver function test, liver enzymes will be like AST and AL will be raised more than 1000 times. And CNS involvement, you can know the GCS, that is Glasgow Coma scale you can do, or the child usually have impaired consciousness, usually less than 7 or 8 GCS will be there. And the heart and other organs, like, as I told you, heart, they may present as myocarditis, viral myocarditis. Any viral infection can present as myocarditis. But what happens, myocarditis leads to initially there will be tachycardia. Later they may present with low volume pulse, with ECG changes, with low amplitude waves and cardiogenic shock. So coming to the investigations, what are the investigations available to diagnose dengue fever? So we can go for the virus detection and its components, like acute serum. Usually acute serum means blood sample taken within 1 to 5 days of the fever, or sometimes death occurs, then necropsy tissues also can be taken for virological detection. To diagnose the viral isolation with mosquito cell culture inoculation usually takes more time, 1 week or more. But nucleic acid, this virus nucleic acid detection can be done by RT-PCR and real-time RT-PCR, 1 or 2 days. Results will come in 1 or 2 days. But there are rapid tests like NS1 antigen rapid test, within minutes we can get. Or NS1 antigen ELISA test usually takes 1 day. Immunohistochemistry 2 to 5 days. What is paid sera? Some paid sera means we should take 2 samples. One at the fever of 1 to 5 days history. Second at convalescent phase, that is serum obtained after 15 to 21 days after the fever. And usually in this paid sera, we will go for the IgM and IgG seroconversion. So by ELISA and HI, that's immunohistocompatibility assay, 1 to 2 days. Neutralization test, it takes minimum 7 days. Serum, only one, not paid serum, single sera, that is serum taken after 5 days of fever. IgM detection can be done. If it is positive, it indicates recent infection. So ELISA, by ELISA test, our rapid test also there. Within minutes we can get the results, IgG and IgM test. So both are positive. NS1 antigen positive means it's an acute infection. So here how the IgM and IgG antibodies rises after first, that is primary infection, and after secondary infection, how they will rise. So in case of primary infection, that means primary infection means first time the child got infected with dengue virus, whether it's a dengue virus 1, 2 or 3 or 4, any serotype, if infects the child, that is called first time, that is called as primary infection. Usually they will present with high grade fever and body pains and sore throat. If you do serum for IgM analysis, it rises after few days, usually after 3 to 5 days, peak around after 6 days only IgM antibodies arises. It will be more weak and subsides after 10 days. But IgG, it comes later than the IgM, but low values, and it lasts in the body only, but low volume. IgG indicates past infection on IgM acute infection. But what is special to this dengue with secondary infection, that is second time infected with the same serotype or under serotype, there will be rise in the IgG first because memory cells will be there. B lymphocytes, memory cells will be there, plasma cells. These will release the second time with the secondary infection or second time infection, more IgG antibodies. So acutely, you can see here it's acute. Here it gradually increases and low volumes, but here it increases acutely and high volume. And it, after few days, after 10 to 14 days, it comes down, but it's not come to the normal value. But what happens to IgM in secondary infection? In initial infection, IgM will increases more initially also, but here IgM appears later and low volumes and subsides very early. Within 6 to 7 days only, it comes to normal secondary infection. So onset of illness and primary versus secondary infection. This is the values of IgM and IgG. So that's why we can delineate, discriminate whether it's a primary infection or secondary infection. Why you should know whether it's a primary or secondary? Because secondary infection will be more complicated, more risk, and there are more chances of getting dengue shock syndrome. So how to interpret these investigations? Mainly NS1 antigen, IgM and IgG antibodies. So if any child came with this report, NS1 antigen positive, IgM negative, IgG negative, that is first time infection, that is primary infection, and the duration of illness is less than 6 days. That's why child may not develop IgM or IgG antibodies. So this is a primary and less than 6 days acute illness. Only NS1 antigen will be positive. NS1 antigen is positive, IgM antibody is positive, but IgG negative. This we can see in rapid test. Most of the dengue rapid test, card test, we can see these things. And this indicates first time infection, that is primary infection, and the duration of illness is more than 6 days, like 10 days or 11 days like that. But IgG not yet developed. So NS1 antigen negative, IgM positive, IgG negative. That's the first time infection, but duration is more than 6 days. NS1 antigen negative, IgM negative, IgG positive. That indicates previous infection. Child had infection with dengue, now it's not having any dengue fever. NS1 antigen positive, IgM and IgG positive. This is second time infection or secondary infection, and duration of the illness is more than 6 days, and the child also had the past infection also. That's why both IgG and IgM antibodies are present. NS1 positive, IgM negative, IgG positive. Secondary infection, duration is less than 6 days, and past infection is also there. So this is the interpretation of serological and NS1 antigen test in case of dengue fever. Okay, any doubts are there regarding this interpretation? Is very important, not only for theory purpose, for practical and day-to-day life also. You should know if any of your relatives or neighbors get this report and ask you whether he or she is having dengue fever or not. According to that report, you should be in position to tell also, guide them also. So is it clear? Any doubts are there? If no doubts, I will continue. So coming to the management, how to manage this dengue fever? Once you label them, the dengue without warning signs, dengue with warning signs, severe dengue. So they will categorize into group A patients, group B and group C. So group A usually without warning signs, you can send home and treat at home. Group B, better to hospitalize these children and monitor. Group C always requires emergency treatment. So who are these Group A. So presumptive diagnosis, presumptive dengue. The child or the person living in dengue endemic area, or he is traveled to a dengue endemic area and he or she is having fever, and any two of the following criteria like anorexia, nausea, rash, erythematous rash, body pains and aches, warning signs, any one warning sign, leukopenia and tourniquet test positive. That is called as probable dengue. Laboratory confirmed dengue means in non-endemic area, no signs of warning signs, confirmatory lab confirmed, then we call it lab confirmed dengue. What are the warning signs? Already discussed: abdominal pain, persistent vomiting, and lethargy, restlessness, all these features make us warning signs. So if there are no warning signs, we can send home. If there are warning signs are there, we'll admit. If they with warning signs, they may go for shock or bleeding manifestations or multi-organ involvement, then we call it severe dengue, needs ICU care. So group A means patients who do not have warning signs and who are able to tolerate adequate volume of oral fluids like oral rehydration solution and rice water and medications orally, and they are able to pass urine at normal intervals or at least once in 6 hours. That's a group A patient we can send home. Group B means patients who are having coexisting conditions, like that means children of less than 1 year or diabetic patients or children who are having any one of existing warning signs. Then we have to admit them and close monitoring is needed. Group C means patients with any of the following features: severe plasma leakage with shock under fluid accumulation with respiratory distress, severe bleeding or severe organ impairment. These children call as dengue shock syndrome or severe dengue. They need emergency treatment. So this is the algorithm how to treat the children with dengue. In the case of compensated shock, that means BP is maintaining normally. Even the shock is there, BP is maintained normally, means we call this compensated shock. So first initiate intravenous IV fluids, usually with normal saline or ringer tractate, 10 ml per kg over 1 hour. We'll see if the child is improving or not. The child is improved, then we will decrease to 5 to 7 ml per kg per hour for 1 to 2 hours. Then we still having improvement, then we will reduce further to 3 to 5 ml per kg per hour for 2 to 4 hours. Then we will reduce to, after he is maintaining for 4 hours normal volume, then only we will reduce to 2 to 3 ml per kg per hour or less according to the clinical response. Is able to take orally means will decrease further. This is the child with compensated shock. If it is child is not improving, then we have to see the hematocrit value. The hematocrit is decreasing, indicates bleeding. We have to start blood transfusions. So first 10 ml per kg per hour, 1 hour will give, will reassess the child is improving, we will decrease around 3 ml per kg like that, 5 to 7 per kg per hour. But it's not improving. For second dose of bolus we will give 10 to 20 ml per kg per hour for 1 more hour. Still is not improving, then we will see hematocrit value or packet cell volume. So PCV or hematocrit value is decreasing than the normal with no improvement. We have to think that there is some underlying bleeding is there. We have to replace with fresh blood. If there is improvement, then after second bolus, then we can go for the 7 to 10 ml per kg per 1 to 2 hours. Then we will follow this algorithm. But one more criteria is there, that is compensated. This is hypotensive shock. That means shock with low BP, hypotensive shock. So here we have to give 20 ml per kg very rapidly over 15 minutes. There we will give 10 ml per kg over 1 hour. But here 20 ml per kg over 15 minutes. Isotonic crystalloids or colloids we can use. Crystalloids means normal saline and ringer lactate like fluids we can use. Colloids like albumin or dextran, that is hemaxil, like that we can use. If there is improvement, we will assess for the shock symptoms and signs. If there is improvement, then we will decrease the fluids. If there is no improvement, check the hematocrit value, that is PCV value. PCV is increasing, high, we can administer second bolus of fluids. Usually colloid we will prefer here because there is a hypovolemic shock we have to and hypotension is there, so we have to act rapidly. 10 to 20 ml per kg over half an hour to 1 hour. Colloid we can give slowly, and we will assess that the chair is no improvement, hematocrit is still high. We can administer the third bolus of colloid 10 to 20 ml per kg over 1 hour. If the hematocrit is low, no improvement, hematocrit is low, consider significant occult or over bleeding and initiate blood transfusion. Here also if it is decreasing means we have to give blood transfusion. But there is improvement with the first bolus 20 ml per kg over 15 minutes. We can decrease the fluids to 7 to 10 ml per kg per hour for 1 hour, then reduce to 2 to 4 ml per kg within 6 to 10 hours and change to crystalloid. So fluid management is very, very important. We should not give more fluid. We should not give less fluids also. If you give more fluids in recovery phase, more chance of fluid overload and cardiac overload and pulmonary edema and cardiac failure can occur. But if you give less fluids, there is more chance of deterioration of shock and a multi-organ dysfunction. The child may die with multi-organ dysfunction. So you should titrate carefully, and these fluids should not be more than the double the maintenance fluid for the child. How will you calculate maintenance fluid? Holiday-Seger formula. According to the child's weight, will calculate for first 10 kgs, 100 ml per kg. Next, about 10 kgs, 50 ml per kg, up to 20 kgs. Like that, we calculate according to the Holiday-Seger formula. Normal maintenance fluid. So while you're giving fluids, you should remember that these fluid boluses should not be more than the double the maintenance fluids. Coming to the monitoring shock states, very, very important. In critical phase, there is chance of shock, as I told you. So child is alert, comfortable, having good Dept, it means shock is improving. And also, what you say, see the vital signs and perfusion, pulse volume. So every 15 to 30 minutes until patient is out of shock, and then every 1 to 2 hourly we have to record the vital signs including pulse rate, respiratory rate, blood pressure and temperatures. And we have to check the hematocrit at least 12th hourly until child pass to the recovery phase. Because depending upon that, we have to titrate the fluids also. If we have to look for pleural effusion or ascites clinically bedside, and also if needed, we can go for the X-ray test. Urine output also you should monitor, and every 1 hour you have to look. The minimum volume of the urine should be at least 0.5 ml per kg per hour, and if it is more than 2 ml per kg per hour, we have to reduce the IV fluid one. Next, coming to the hematocrit, as I told you, monitoring, usually rising or persistently high hematocrit with stable vital signs. That means we have to decrease the fluids. Decrease hematocrit with unstable vital signs, to give blood transfusions. Decrease hematocrit with stable vital signs, you think we have to fluid overload, so decrease the fluid input. Total IV fluids per 24 hours should not be more than double the maintenance fluid. That all of you should remember. When to stop intravenous fluids. So it's very, very important when to stop intravenous fluids, because otherwise fluid overload will occur. So features of intravascular compartment overload, like hypertension with good volume pulse, breathing difficulties and pulmonary edema signs are there. Stop IV fluids. 48 hours after defervescence, fever subsided for more than 48 hours, there is less likely of shock. Complications are of dengue fever are prolonged and profound shock, severe bleeding with severe dick, fluid overload, respiratory distress with respiratory failure or cardiac failure that develop, multi-organ failure, and rarely irreversible shock and death. These are the complications of dengue fever. How to prevent this dengue fever in children? Avoid mosquito bites through the use of insecticides, mosquito repellents, body covering with proper clothing, screening of houses for mosquitoes, and covering open water sources with proper lid and everything, and destruction of Aedes aegypti breeding sites is very, very important to prevent the dengue fever. The water storage is a must, mandatory, not available water 24 hours. Then we have to cover with tight fitting lid or a thin layer of oil. So that may prevent egg laying and hatching. Prevention by larvicides such as abate can be used. Low volume, ultra low volume sprays effectively disperses the aldehyde side, that is malathion. You will be seeing regularly they're spraying the malathion. And also recently vaccine is also licensed, not in India, but endemic countries like Mexico and Thailand and some countries. Since 2015 onwards, they licensed this dengue vaccine, that is Dengue Vaxia. It's a tetravalent vaccine, consists of live attenuated 4 serotypes. But disadvantage with this vaccine is we can't give to all individuals. Only in endemic area, seroprevalence should be more than 80 to 90%. Because if you give dengue vaccine and child never had infection, if they after vaccine, if they get the infection, they will have severe complications. So before giving dengue vaccine, you have to see the sero positiveness. Only in seropositive individuals only we can give dengue vaccine. That means the dengue vaccine will act like a second time. So it prevents the further attacks. But if it is first time we are giving dengue vaccine, next if he gets infection, cross-reacting antibodies will be produced and they may get severe dengue than non-vaccinated individuals. That is a disadvantage with dengue vaccine. That's why not at licensed in our India. What are the do's and don'ts of dengue? All of you know, remove the water from coolers regularly and other small containers where water is stored. So at least once in a week, like proper disposal of this used coconut shells also very important. Nowadays people are drinking coconut water, so all should be disposed carefully. And use of aerosols during the daytime to prevent the bites of, because these mosquitoes usually bite daytime only. And do not wear clothes that expose arms and legs, so more chance of mosquito bites. And regular uses of mosquito nets and mosquito repellents is very important to prevent dengue fever and other arthropod diseases. Any doubts are there? Jyoti Prakash? If anybody is having any doubts regarding dengue or dengue vaccine or dengue investigations or clinical features, can ask me.
No, ma'am.
Okay, then I will end. This is important for your SPM topic also, SPM theory also. Okay, then I will leave. If there are no doubts, thank you for listening. I will end this meeting.
Thank you, ma'am.